Okay, good evening, everybody. Thank you for joining tonight's webinar. You are on the right webinar, don't worry. It's usually my colleague Chloe Gronow who's hosting these, but tonight it is myself. Chloe has taken some well-deserved holiday time, so you've got myself hosting and moderating tonight's webinar. Those of you who don't know me, my name's Simon Haratinian. I'm the Commercial Director for the Regenerative Aesthetic Medicine Institute. And tonight we are going to be talking about why all PRP is not the same. This is an independently run RAMI webinar, and I'm delighted to be joined this evening by our industry colleague, Claudia McGloin. Claudia is a specialist medical aesthetic and orthopedic nurse practitioner specialising in PRP treatment. She holds dual registration in the UK and Ireland with more than 27 years experience in healthcare. Claudia has developed expertise in aesthetic medicine, regenerative therapies and functional health, and speaks internationally and contributes to multiple publications and educational resources. We are also delighted to say as of this year, Claudia has joined us as one of our advisory contributors to RAMI and to the industry, and to the institute. Sorry, so we welcome Claudia on board to the team. As always, we're going to start with a couple of questions for those of you who are joining live, just so it gives Claudia a little insight in terms of who's on the call. And then throughout the webinar, you do have access to the Q&A function box, and this is either at the bottom of your screen, and if it's not appearing, there may be three dots there for you to click on, and there should be a Q&A function. So please utilize that and post your questions to Claudia. We'll try and run the presentation up to 45 minutes and leave about 15 minutes or so for a Q&A at the end and wrap up by about 8 p.m. So we will just start with a couple of questions. So the first one, as always, is we just want to get an idea of your medical profession. So to see who's joining us on the call and what your medical profession is. So that should come up on your screen now. So I can see the answers coming in. That's great. Thank you to everyone who's participating in that. Just end that, and then Claudia, I've just shared that so you can have a look. So 56% of you doctors, 13% nurse practitioners, 6% dentists, and 19% others. So thank you for that. And the second question, the topic tonight is PRP usage. So we just want to get an idea, simple question really. Are you currently using PRP as a treatment in your clinical practice? So again, that should have come up on your screens. Now, again, I can see the answers coming in. So thank you again for sharing that. Again, it will give Claudia a good indication of who she's speaking to tonight. So we can see that. And Claudia, yeah, as you can see, we've got 65% yes, are using PRP as a treatment, and 35% no. So a nice mix on board tonight. So thank you very much. That's great. That's the end of the poll. I'm delighted to hand over now to Claudia. Claudia, over to you, and I'll speak to you again with the Q&A at the end. Over to you.
Lovely. Thank you so much, Simon. And hello, everybody. Good morning, good evening, good night, wherever you're coming from. I'm delighted to talk about one of my passionate topics on why all PRP is not the same. And I'm glad to see that some of you on the webinar tonight don't do PRP. So hopefully by the end of this session, you will all want to come on board in regenerative medicine and do some training, and hopefully even do some training with myself. So Simon did introduce me. I've been nursing now for over 28 years. My background is trauma and orthopedics, and I moved into regenerative solely about 14, 15 years ago. So I have quite extensive experience. So I sit on editorial boards. As Simon said, I'm a contributor for RAMI. I am a KOL for Selinus, and I work quite closely with AMP. And I've got some columns on a monthly basis, and I'm also pretty much known as the princess and the PRP. So let's get into why all PRP is not the same. So we all know that it's simply a concentration of platelets, and the question is If it is just a concentration of platelets, then why do some clinicians achieve different results? Usually when I'm presenting internationally, I get people coming up to me afterwards saying that they've fallen out of love with PRP, or they're getting various results with their patients. You might see that yourself in clinic, that if you're doing, let's say, a skin rejuvenation treatment, that you've gotten a really good result with patient A, but patient B might take a couple of treatments and you're not getting the results that you particularly want. We all know who this is. This is Kim Kardashian. And even this is not a platelet-rich plasma treatment. So the background to this, if you don't know, is while Kim was recording her TV show in the States, she had what was called the vampire facial, which is the American version. So this is platelet-rich plasma, but it's needling. And we certainly don't smear red blood cells on your face and leave you looking like this when you leave. So what I want to do tonight is I want to bring this back to basics and discuss why all PRP is not the same. Some of this you will know, but some of it might make you think, and hopefully it will give you some pearls that when you go back to your practice tomorrow, that you can implement. So we all know that we take a specimen of blood, we spin it in a centrifuge, you have your platelet pore that sits on the top, your platelet-rich plasma is on the bottom, and we don't use your red blood cells. And then we inject our platelets into hair, face, intimate, breast, wherever we're injecting. So if we talk about the variations, so the variations will start with yourself as the practitioner. Who are you? What is your background? Are you a doctor, a dentist, a nurse? Are you used to taking bloods? Who's trained you? Also, the patient. The patient is the most important part in this process, and sometimes the patient gets overlooked. Because if a patient comes into your clinic tomorrow morning and says, I want to have a treatment, some people will go ahead without prepping the patient for the treatment. But we need to know, who is the patient? What age is the patient? Because age matters. The oldest patient that I have injected is 80, but we want to make sure that these patients are fit and well. So we're looking at their diet, we're looking at their lifestyle, we want to know whether they smoke, we want to know what medications they're taking, whether they're supplementations, whether they're over-the-counter medications or recreational drugs. Your kit, the PRP tube, is extremely important, and I'll go through that, the differences in tubes in a little bit. The centrifuge is extremely important. And also the blood draw. How many attempts at a blood draw are you making? And also the tourniquet. How tight is the tourniquet? How long have you left the tourniquet on for? I do some bloods in our clinic, and recently with the private lab, we've been having discussions because some patients were coming back with very high potassium levels in other clinics, and that was all down to the tourniquet. So the tourniquet can affect the platelets. So we also need to look at the clinical variations, and that is the injection techniques that you're using. Are you using a needle? Are you using a cannula? Are you needling? The protocols that you're using. Everyone has different protocols, and I suppose when you look around the world, different clinicians will use their different protocols, different amounts that they're injecting, and different amounts of treatments. And then we're certainly seeing a lot more combination treatments. And coming into regenerative aesthetics, we're certainly seeing PRP being used in combination with polynucleotides and exosomes. And all of this will have a huge variation on the treatments that you are using. So if we talk about the tubes, they're not all the same. They come in a variety of shapes and sizes, lots of colored tops. You need to make sure that they are CE marked, FDA approved. Some of these tubes are glass, some of them are plastic. Some of them will contain an anticoagulant, some of them won't. And some of them will have a separating gel. And all of this will give you a different amount of platelets. So this is something I absolutely have to bang the drum on. Please do not use these tubes for your platelet-rich plasma. These are for diagnostic purposes. They are not sterile, and the contents should not be injected back into a patient. I see so many videos posted on Instagram where practitioners are using these tubes. please don't. We have had issues in the past, and you may remember Kerry Katona many years ago who had an allergic reaction, and this is the outcome following being injected with the contents of one of these tubes. So let's look at centrifuge. A lot of people are going on to eBay or AliExpress and they're spending $20 on a centrifuge. I call them Fisher Price centrifuges, and I would ask you please not to do that because there are so many variations within the centrifuges as well. So you will see some of them have a fixed angle, some of them are horizontal. We talk about the single spin and the double spin, and that comes with the different kits as well. Some of these centrifuges will have different times and they're set differently. Some of them you cannot alter the settings at all. Some of them you can. So the speeds are very different as well. And there's low versus high. What you want to do is you want to get the compatible tube for your centrifuge. And you don't want to have something that's not set to the right speed for the right time. A few years ago, I did some little experiments in my clinic with different tubes and the centrifuges, and they're not all compatible. It doesn't always work. Even if you think that something is suited, it actually isn't. And also you need to make sure that, again, that they are CE marked and FDA approved, because a lot of these cheap ones that you're buying, they're not. So what exactly is inside your tube? So we've spun it, we're taking out the platelets. So with all of these different kits on the market, we have different amounts and concentration levels of platelets and growth factors. Some of these will have leukocytes and some of them won't. So you'll see papers, you'll see, if you've heard me present before, you'll hear me talk about leukocyte rich versus leukocyte poor. And we've also got to look at the red blood cell concentration level. So if you've got a tube that doesn't have a separation gel, you run the risk of contaminating your platelets with the red blood cells. And that's something that we really don't want to do, because that's where you're getting the stinging, it's where you're getting the burning. And also we have to look at the amount of platelets that's left when you spin everything, because again, you've got different tube sizes. So they vary from 11 mil, 22, there's 40. You want to get the optimum amount of platelets for your treatment. And we want to know the concentration ranges as well. So people talk about the buffy coat and the leukocytes. So obviously with leukocyte-rich PRP, we've got a higher cell content of white blood cells versus the leukocyte-poor that has lower. If you have leukocyte-rich, you've got a greater inflammatory response as opposed to the leukocyte-poor. Interesting, as orthopedics, which is my background, we tend to go for leukocyte rich because we do want to get a little bit of inflammation to heal, but some people would prefer not to have the leukocytes in their platelets. But I have been using a system now for a few years with low leukocyte, and I'm getting amazing results with my orthopedic patients. So it just depends, again, on the kit that you're using and your protocol. So this is just a quick table that kind of compares some of them on the market. I do have other slides that have the actual amounts. So if you want, just reach out to me and I can share that with you. But as clinicians, what you really need to be asking, and I guess this is your homework. So when you're in clinic tomorrow, you need to ask the questions from your reps or the companies that you're buying your tubes from. What is the platelet concentration that you're getting from that tube? Are there leukocytes present? Is there red blood cells in there? What is the volume that you are delivering? And once you look into your kits, then you know exactly what it is that you're offering your patients. It's not a one size fits all. So again, we have activation. Some of you may know that you can activate your platelets prior to injection with calcium chloride. Some of you probably do this, some of you probably don't. You can activate if you want. Many years ago, when I started doing platelet-rich plasma, I was activating. And some people say you don't actually have to. It just means that the growth factors are releasing that little bit quicker. But as soon as you activate, you have to inject straight away because you can damage your platelets. For me, I've not been activating now for a long, long time, and I'm still getting some really good results. But I do think it's down to the kit that I am using. So obviously, with these protocols that you're using, it is going to have an impact on some things like your skin rejuvenation. I see people advertising that patients need 4 to 6 treatments. Not necessarily, because I've had some really good treatments or some really good results from one treatment. Sometimes we might have to do 2 treatments. And again, it's all depending on the depth that you're injecting, the volume, the protocol. And again, if we look at hair, it's going to be the same, because how many sessions are you offering your patients? And again, just remember that while not all PRP is the same, it's not a one size fits all. So your patients, again, are different. As I've already mentioned, that's a very old picture of me many years ago when I worked at the Royal London Hospital. We do like a little bit of inflammation, but some of these kits are absolutely fine to use. So does variability matter? Absolutely. And one of the things is you're going to keep seeing inconsistent results. You're not going to be happy. You're going to lose faith in the treatment. You're not going to offer it to your patients. But more importantly, you're going to have a lot of unhappy patients who will not come back for a second treatment, may not advertise your business or tell their friends or their family to come to you. And I get it a lot with people. They tend to text me asking me, what kits do I use, or can I share my particular protocols, because they're not happy, or what they tend to think is that all PRP is the same. And so when they come to listen to one of my presentations and they see the science behind it, and they get to know exactly what tubes they're using, then they fall back in love with it again. And hopefully, if some of you on the call have kind of fallen out in love, hopefully you fall back in love by the end of tonight. Some of the challenges that we face globally is we don't have any standards globally. We don't have universal guidelines. I have been doing this for so long that I will share what I do and what works for me. You might get another clinician in the States to say, I've been doing it for 20 plus years. This is what I've been doing. But we all know that because we don't have something universally, the only thing that we know is we're taking the blood, we're spinning it and injecting it back. And because we've got differences with our centrifuges, we are going to see different results in studies and research papers. So we do need to do a lot more research on platelet-rich plasma as we progress. One of the questions I get asked a lot is, you may see there is an awful lot of research papers out there, and sometimes you'll get mixed results. And a lot of the time, it could be poor platelets that have been researched. Some of these trials, they're not where they should be. And so definitely we need to do a lot more of this. And sometimes people would say, but it's anecdotal, and there's not really a lot of evidence out there. There is. So one of the things I will tell you is the first growth factor was first discovered in 1952. And the scientists went on to win a Nobel Prize. So subsequently, from 1952, every few years, they start discovering more growth factors. Sometimes that shocks people because they look back at that picture of Kim Kardashian and think, oh, I thought that treatment was only 13 years old. It's not. We're over 70 years now since we found those growth factors. So it's not a new treatment. It has been around. It started off in orthopedics, cardiac surgery. It's used in veterinary. There's so many clinical indications for it at the moment that it's mind blowing what we can use it for. So I definitely think we do need a lot more research and some trials definitely to demonstrate what we know, because every time I do a treatment, I have to say it blows my mind because of the results. Patients will come back and say to me, you told me that I wasn't going to see a result in my skin for maybe 5 to 6 weeks. with orthopedics, they're telling me within 2 weeks, oh my gosh, the pain definitely is a lot less. They're able to mobilize better. So we definitely need the research to back all of this up. So it wouldn't be a presentation if I wasn't talking about patient safety. I am a huge patient safety advocate. I have sat on a lot of committees at government level in Ireland, and I was part of that JCC committee regarding PRP. So we have to talk a little bit about regulations. So we have no regulations here in Ireland. And I have to say, when I'm presenting internationally, I'm mortified standing on stage, having to say that we live in the wild, wild west. And I see colleagues from Asia or even the EU, and it's so strict over there. Thankfully, we've now got the JCCP guidelines, we've got CQC and MHRA, and hopefully Ireland will catch up a little bit, but it's a continual fight to get where we need to be. So we will hopefully see PRP in the red category. So when we talk about platelet-rich plasma and safety, when I first started doing this treatment, I was advertising that it was 100% safe, there was no risk. It was autologous, meaning it's coming from the patient's own blood. The patient's body won't reject it. They're not going to have any issues whatsoever. They won't have an allergic reaction. And what I will say is I was writing an article for the Journal of Aesthetic Nursing during lockdown, and I was coming across some of these papers that had already been written about complications. And I started to delve a little bit deeper into it, to the point that I was shocked, because when I did my training and I wasn't told about complications. And so the main reason we don't see a lot of complications being advertised is probably because they're not all reported. They're often misdiagnosed, and I'm not talking about bruising or swelling. A lot of the time they're dismissed. So people might say, oh, you know, that's going to be fine. Give it a couple of days. It'll settle. But you need to be vigilant, because if you see something, report it to MHRA, report it to the company that you've bought your tubes from. Please reach out to myself. A lot of clinicians do. If something is niggling, if something that you feel is not right, sometimes it's not. So the majority of these treatments are uneventful. It is an amazing treatment. It's certainly safer than using your dermal fillers, but I want to educate you about the fact that complications can actually happen. So we class them from mild to severe. However, some of these rare complications are occurring, and we're seeing more and more. When I was putting the final touches to this presentation on Monday, and I happened to see that there was something else, a 22-year-old girl who had loss of vision. Thankfully, it was reversed following PRP for hair. So every time I'm doing, whether it's an article or a presentation, I'm seeing more complications globally. So we have seen allergic reaction. This had occurred in a 14-year-old boy. We're seeing nodules, HIV, a lot of inflammatory reactions, and certainly irreversible blindness. So one of the articles that I had written in 2022 probably was one of the longest articles that I had written. It was 15 pages long, and it was on irreversible blindness. And when I first saw this, I thought, how can platelet-rich plasma cause blindness? And I did quite a lot of research into this, and I will talk about this because we are seeing this happen a lot more. So you've all seen the press articles on the vampire facials and HIV, and this was from New Mexico some years back. But it rears its head again every so often, and these cases are still, the cases are still kind of ongoing, even though there was only 2 to 3 patients in New Mexico. So this is one of the articles that I had written. I can send you the links, or you can take a screenshot of it. And this is the article that kind of catapulted me into the whole realm of patient safety around platelet-rich plasma. So with blindness and platelet-rich plasma, there has been 7 reported cases around the world of irreversible blindness, and we have one case of vision loss. Interesting is that these cases were all skin rejuvenation treatments treating the glabella in forehead and nasolabial folds. So we all know that these are the areas that we do need to be very careful with. Now, there was another case, and it was retracted. This case was actually in the UK. So this is the retraction that they had put out. So when I delved into it a little bit, we saw that there was 4 in Venezuela, 3 in the US, 1 in Malaysia. The case in the UK, there's still a little bit of a question mark over it, and I have contacted the authors just to see specifically what exactly has gone on. We have liquid PRP, but we also now can convert it into a gel. So it's called a PRP dermal filler or a biogel. So some of these cases may be that it has been the gel. So all of these patients were female, which is really, really interesting. Some of the other complications, there are males there as well, but this is interesting that all of these cases were female, and their age, the age range was between 37 and 63. But each of these patients had no underlying medical conditions. For a lot of these patients, this wasn't their first time having a platelet-rich plasma treatment. They had undergone quite a lot, and it was all uneventful. So the one thing we know about all of these patients is they all describe the same thing, the same protocol. Having their blood taken, it was spun in a machine, and then it was re-injected back into their faces. There will be a lot of questions probably around who's done the treatments, what was their backgrounds. Some of the information is a little bit sketchy, but we do know that there were cosmetologists, a dermatologist. We know one was an unlicensed injector, and a couple of them were just not sure if they were medics or lays. So with the 8 cases, they suffered immediate blindness, and their symptoms were pain, nausea. Some of them were vomiting, dizziness. They had headaches and numbness in the area that was treated. So some of these patients were followed up. Only one of them was followed up to 12 months. One was followed up to 8 months, but the majority of these patients weren't followed up at all. So I will go through one of the case studies because it is quite interesting. This is a 61-year-old lady. She is fit and well, absolutely healthy. She's had about 6 treatments of platelet-rich plasma over the course of a few months and years. All treatments were uneventful. She was having a few sessions for skin rejuvenation, treatments to the back of her hands. As soon as she was injected, she had sudden pain and vision loss. Luckily, she was taken to hospital and she had an examination, and it did show that she had 20/20 vision in her right eye, and no perception of light in her left eye. So this is one of the ladies that had been followed up to 8 months. So she was reviewed again 3 days later. They saw that there was very limited and sluggish filling of her retinal arteries. She had quite a lot of bruising in the glabella. She was brought back again at 1 month, and they could see that she had developed skin necrosis and ulceration. And they could see that there were issues with her optic disc as well. So these are some pictures of her on her journey. So as I said, she was reviewed again at 4 months, and her skin necrosis and ulceration had improved. And by the time she was reviewed at 8 months, she had retinal detachment and she had some scarring. So with every treatment that you do, regardless within medical aesthetics, it's not 100% safe because everything we do comes with risks and complications. So in order for you to manage or prevent these complications, your patient selection is crucial. So definitely doing a deep dive with your patient. strict aseptic techniques. I cannot begin to tell you that I cringe sometimes when I see people putting videos up on Instagram where they're using cotton wool balls. They don't have their sheets on the bed. Sometimes they're not wearing gloves and they're just not practicing aseptic techniques, especially if they're injecting joints. You don't want a patient to come back with an infection in their joint. Obviously, I mentioned before, we don't have standardized protocols, but I think we can all work from a basic protocol to know exactly what it is that what's working and what isn't. I would say that you do need to have adequate training. I could teach you how to do it in 10 minutes, but if you don't know the theory and you don't know exactly where you're injecting, if you don't know your anatomy, then this is where we're going to see some of the issues. Injection techniques as well, they vary. Whether you're using a cannula, whether you're using a needle, you just need to know your landmarks. What I would say is stick within your remits for treatment. So if you're not orthopedically trained, for example, don't start injecting joints. It might look easy to inject, but if you're not orthopedics and you come up with patients then after treatment with complications, it's not going to be good for you. And one of the main things is inject really, really slowly. Looking at all of the research papers and the case studies, one of the things was about injecting slowly. They think that one of the main reasons for some of these cases of blindness was that it was injected high pressure in high risk areas. So what you need to do is if you see something, try to recognize this immediately, act straight away. Time is critical. When I worked at the Royal London, we always talked about the golden hour. Have a pathway in place. Whether you're a lone remote worker, who's around you, where's the nearest hospital, and kind of set out if something does happen, what you're going to do. Always have a face-to-face consultation with your patient. So always, if they call you and say, "Oh my God, I'm really bruised. This is really sore. It's really swollen," get them back in. Sometimes there is a lot of hand holding, but we do need to reassure them. But we also want to make sure that nothing serious is going on, that there's no infection, that nothing sinister is happening. And we have seen vascular occlusions. It can happen. So definitely if you are doing the biogel, you need to have some good protocols and pathways in place for that. So my key takeaway for all of this is PRP is powerful. It's an amazing treatment. I will say buy cheap, buy twice. So do invest in a really good kit, invest in a really good centrifuge. Even if you're thinking of changing to a different brand of tube, you can always talk to the companies to see if the centrifuge you have is compatible. Some of them aren't, some of them are. As I said before, please make sure everything is CE marked or FDA approved. And just remember that even though it is autologous, it doesn't mean that it is risk-free. So just be very, very careful with that. So if you've any questions at all or any burning issues, you want any info on training or anything, please just get in contact. These are my main details. And I've just realized throughout this presentation, there's like a million different photographs of me. So take a screenshot, get in touch, and I'm happy to answer any questions that you have. And I'm just going to stop sharing and see what's going on.
Thank you very much.
Oh,
Thank you. Can you see me and hear me?
yeah. Oh my God. There's always dramas when I do presentations, and normally I can blame the tech guys, but because I'm doing it solo tonight, I'm thinking, oh my God, I don't want to mess up.
Don't you worry, no mess up at all, and hopefully we had everything under control. Claudia, thank you so much for the presentation. That was brilliant, and I really appreciate your coverage of the case studies and the complications. I think whatever webinar, education, delivery, conference, we do have to cover it as scary as it may be, but I really
Yeah.
appreciate that. So thank you. Just for everyone on the call. the Q&A function box is open, so feel free to drop your questions in there. And from me, just one thing before we go to the Q&A, Claudia, you touched on the research and the trials, and although this has been around for the decades, we're still at a stage where we want more research, more trials, and I do urge people really. I mean, this webinar is from the Regenerative Aesthetic Medicine Institute. We are trying to build a community around the topic of regenerative aesthetics in medicine. So, if anyone's got any feedback, if they've got any comments, we do urge you to touch base with us. We've got our scientific board, we've got our advisory contributors, we've got the Journal of Regenerative Aesthetic Medicine that goes out 4 times a year. We've got the Ramsey Conference at the end of the year as well. So we've got a number of platforms and opportunities to continue building the community really, and things like feedback around research and trials is always warmly received. And as Claudia touched on at a few points during that webinar, don't be afraid to reach out to us, and we can put you in touch with our board and our contributors, because this is with all of this education, it's two-way traffic. So we do urge you to communicate with us and reach out to us. So first question, independently, Claudia, because as one of your slides mentioned, there are numerous manufacturers, suppliers of the PRP kits. How do you source, in your eyes, what is the best kit, and what do you use in your clinical practice?
So what I would advise everybody to do is go and do your own research. Have a look at all of the different kits that's on the market. So you want a kit that's easy to use. You want it to be a closed system. So you can ask for papers from the representatives that they've got, where lots of research has been carried out from the different companies. And certainly when you're going to any of these conferences, you'll see the stands all around. Go and speak to people. Ask your colleagues as well what they use. And certainly for me, in the 14 years, have used quite a lot of these kits. And at the moment now, hand on heart, I have to say, because I use Stellantis, it is, for me, the best kit. Now, you will see, I did put up a slide where all of the different kits, and I suppose, again, there's more research coming out to compare all of these different kits that's on the market. So don't be afraid to reach out to all the different companies. And again, they're all different. So as I said, some of them, you've got PRF, platelet-rich fibrin. So definitely just reach out, even get in contact with me. I don't mind. But one of the things I will say is, because I work quite closely with the guys from AMP, and we've just done a case study. So a patient of mine that has been coming to me for about 13 years had treatments with me with different kits. And she was one of the first patients that I had used the Stellantis kit with. And straight away, she said, I see the difference pretty much straight away. I can see the texture of my skin, the tone, the fine lines and wrinkles, and she felt this was a better treatment for her. And at the time, she didn't know what was happening. She didn't know that there was a difference in the kits. She happened to be a model for one of the conferences that I did. So it's nice to get feedback like that as well.
Great, thank you. And regarding training, again, I know you touched on it briefly during the presentation, but like you said, I think you said you could train in 10 minutes, but obviously there's a
Yeah.
bigger picture. What is your recommendation, especially in the industry at the moment? We know whether it's PRP or other treatments, there's a lot
Yeah.
of training out there, a lot of training providers. What would be your advice to any practitioner, I guess, from entry level all the way through to experience, if they're looking to either go back into PRP or starting out? What would the starting point be there?
So you need to make sure that whoever is training you has been doing this for a long time as well. Not that they've just done a course themselves and now they're going to train you. So look at some of these good training companies in the UK. And again, the companies that you're going to choose will also offer training. I do my own independent training as well as training with AMP, and I share my protocols. That's something that you want to make sure that people are, sharing their protocols. but also if something happens that they're there for you as well, that they're not just going to take your money, train you and send you on your way. And I think if you look at the JCCP guidelines, because we've been going down this for over a year now, is we want to make sure that everyone has good training and you're going to get insured for that. If I just showed you quickly, oh look, this is how you use the kit. It's kind of like what we call a see one, do one, teach one. You may not, there may be issues if you come up with a complication, because the first question they're going to ask, or even if you were in court, who trained you? And if they're not satisfied that the training isn't adequate, and also you need to keep case studies as well for yourself. Um, Especially like doctors and nurses, we have to keep ourselves on the register. We have to prove that we've gone to our CPD accredited courses and meetings and conferences. So it's the same. So think of it as the same as well. And then you've got like your case studies. So when it comes to maybe next year, if they want to present at Ramsey, that they can present some of their amazing cases. Because like I said, every time I do a treatment, it does blow my mind for the different indications. And sometimes you think, like I'll share one of my cases. It was an orthopedic patient. He traveled about 3 hours to me, and he wanted his knees injected. And straight away, I thought, you need a knee replacement. This isn't going to do anything. And he said, I can't have a knee replacement just yet. I have to wait until I retire. And I thought, the worst thing you need is for you to fall and end up fracturing your spine. So I did a treatment, and about 7 months later, he came back for a top up, as he called it. He said the pain had just decreased significantly. His knee wasn't giving way, and he felt the best that he had ever had. And I thought, oh, so he's a case study that I use. And I have to say, 2 years on, he still hasn't had his knee replaced. So sometimes as well, even with hair rejuvenation, I've had amazing results with one treatment, as opposed to maybe doing 3 or 4 sessions. So definitely people need to kind of come together. And this is definitely what Ramming will do, because everybody, if we share our case studies and share our protocols, because I always say, I'm not saying that my protocols are the best, but this is what's worked for me over the last 14 years. And I think we all need to learn from each other. And hopefully at some point, we'll get a universal guideline, we'll get a universal protocol.
Great, thank you. You've just mentioned hair there. We've just had a question come in. I have a case of white hair starting to change back to black after 3 PRPs. Have you had this experience?
So they've got white hair initially, is it?
Yeah. The question is, I have a case of
Yeah.
white hair starting to change
Um,
back to black. He or she has used horizontal spin 21 ml bottles, no gel, excluding the BC. Normally, I inject about 12 ml PRP.
it has been, yes, it has been reported that their hair will, yeah, can come back and can come back darker. And definitely we've seen this with polynucleotides as well. Especially, yeah, it can happen.
Okay.
They'll be delighted. They'll be like, oh my gosh. Because especially with hair, there's a lot of hand holding. Because sometimes I think, especially the men, you do a treatment and then they feel that they should have a full head of hair the next day. So no, that's a good indication. So they will love you for that. They have
Yeah.
to go and get the rest of their hair dyed, but yeah.
Great. And you did touch a bit on the protocols. Just to cover off again, for those unsure, what are the injecting protocols and how many treatments are you looking at for what you do?
So a few years ago, everybody was saying for facial rejuvenation, you would need 4 to 6 treatments. I would go by treatment basis, and it will depend on the indications that you're looking to treat. It depends on your patient, because your patient is the most important, and that's why you need to do a thorough deep dive, a really good consultation and assessment. Sometimes you do know that you need a couple of treatments. So we know with hair, we do need to do more. We know with orthopedics, we might need to do a couple. But again, it's coming down to the kits that you're using. Because if you've got really good quality platelets, you're going to see a better result. And it's down to the patient as well.
Brilliant.
Age is
And
a factor, but it's it's not, because I've injected an 80-year-old because she ticked all the boxes, and it was like, okay, we can do the treatment.
And this question always comes up as well, just on the treatment protocol. Needles and cannulas, your view on using those.
I'm old school, so I prefer needle. I think I can get my PRP strategically placed at the different levels, and I inject at different depths. You certainly can with the cannula, but I think for me, needle. Um, and I would go superficial, medium depth, and deep down to periosteum as well with the needle.
Great. Okay. Thank you so much. We have had a question about the slides as well, just to let anyone watching live today, the webinar is recorded. So I think tomorrow evening, 24 hours after this is passed, you will have a link to the recording of this webinar. So you'll be able to see all of Claudia's slides again. If there's anything particular, I think we had a question about the different products on the market and what's available. If there's anything specific that you want that slide, we can always grab that individually and forward
Yeah,
that to
and
you.
also what I will say is because this is an independent, I'm not talking about any one brand or any one kit. I haven't purposefully put in slides regarding the different kits. I think it's just important to know that not all PRP is the same, and then hopefully you do your research. I can certainly help you along the way, and just reach out if there's anything that you're unsure of.
Great, thank you. Time for one more, Claudia. One more's just come through. Slightly different one here, actually. What gap do you use for frozen shoulder? If a client wants no steroid injections and physio does not help. Female client, postmenopausal, well, not on medication, only HRT.
Just repeat the first part. What?
What gap do you use for frozen shoulder? I think if that's what's written on the question. If a client wants no steroid injections and physio does not help. So this is for a female client or
So it
patient.
is. Frozen shoulder is a symptom of peri and post menopause, and it's probably one of the symptoms that people don't know about. When you say gap, what I don't know specifically what you mean. Is it like a gap between different
It's
treatments, or where?
they've just put it in actually gap between the sessions.
Oh, gap. So
Thanks for
with
clarifying.
so what I tend to do is I do one treatment and see how they go. They will come back and tell me if they feel they need another treatment. But rule of thumb is 4 to 6 weeks between treatments.
Great. Thank you. Thank you everyone for your questions. Thank you, Claudia, for the answers as well. I hope that's been helpful. Like I said, this is recorded, so within the next couple of days, this will be live on our hosted library section on the e-learning part of the Institute. Where you can see the previous webinars as well. I think this is our fifth webinar of the year. So these were introduced this year under the Institute that we wanted to include the webinar. So this is the fifth. We've got a couple coming up as well already in the diaries. So mark your diaries for Thursday, 25th of June. We've got Pirral Sideras talking about the treatment readiness and regenerative aesthetics, why outcomes start before the injection. And then in July, we've got something pretty new, pretty different, where we've got a five-part series. I think it's every Wednesday, and it's on genetics and a regeneration series with Gustavo Torres. So that's every Wednesday in July, a whole series of them. So that's all available to register on the e-learning side of the RAMI website. As of today as well, we've got our preliminary agenda now live on the RAMI website for Ramsey on Saturday, the 7th of November. So please go and have a look at the preliminary agenda. We've got an early bird discount up until the end of July. And we also have on the e-learning side of things, obviously the recordings of all of the webinars we've hosted as well. I think that's all the time we've got for tonight. Claudia, thanks again for your time and your expertise and your wonderful presentation. Really, really insightful. I'm delighted that we're going to be able to house that now for eternity on the RAMI e-learning platform. So, any of the folk who have registered for today's webinar and were unfortunately unable to attend live, you won't miss out. You still get to watch this on a record. And all that's left to say is enjoy the rest of your evening. Claudia will catch you soon, and I hope to see all of you again very soon. Have a good evening. Thanks a lot.